Good day, and thank you for having me. My name is Tedla Kebede, an associate professor at the College of Health Sciences at Addis Ababa University. I'm a consultant endocrinologist, and today I'll be talking to you in the coming few minutes on the pathogenesis of type 1 diabetes mellitus. As you very well know, type 1 diabetes is the commonest type of diabetes in children, although children can be affected by many other types of diabetes, particularly type 2 diabetes, parallel to the obesity epidemic that the world is experiencing, other rare metabolic abnormalities, particularly diabetes, associated with genetic abnormalities, mitochondrial diseases, other polyendocrine disorders. So type 1 diabetes is the commonest type 1 diabetes that occurs in pediatric age group. Diabetes classification is generally based on the history of a patient, the presentation modality, and the laboratory studies that would support the diagnosis. Although classification is not very perfect, distinguishing between type 1 and type 2 diagnosis and other specific type of diabetes is very important. As it is clearly known to you, insulin is a major hormone that regulates body's blood glucose. It also is a hormone that is the primary hormone to dispose glucose into the cells for energy production, and the production of insulin in the body differs depending on the different circumstances under which the person is. Insulin, besides it is generation of energy by glucose delivery to the cells, it's also an anabolic hormone that is involved in the synthesis and the storage of glycogen, which is a storage form of glucose. It's also a hormone that synthesizes and stores fat, hormone that is involved in the synthesis of protein, so it is an anabolic hormone. Type 1 diabetes, as I said earlier, is the most common type of diabetes in pediatric age group, and this results from little or no production of insulin from the pancreas. Children who has got type 1 diabetes are oftentimes affected by this disease because of the immune destruction of the beta cells of the pancreas. As a result of this, this is an autoimmune disease process, which can also have other autoimmune diseases together with the diabetes occurrence. Commonly, thyroid diseases and celiac disease or autoimmune enteropathy are among the common autoimmune disorders that are associated with type 1 diabetes. The prevalence of type 1 diabetes is not that rare. It occurs in at least 1 out of 300 child. Every child out of 300 will be affected by diabetes in its prevalence when the child reaches 18 years. So in children that reach 18 years of their age, 1 out of 300 children is affected by type 1 diabetes. The prevalence of type 1 diabetes is increasing globally these days, and the rate of increase is reported to be between 2 and 5% of current diabetes prevalence. The greater increase is being seen in the age group of 10 to 19, which is the teenagers age group. Although type 1 diabetes can occur at any age, the commonest time when type 1 diabetes occurs has got two major peak times, peak ages. These peak ages are ages between the age of 4 and 6 and the age between 10 and 14. This is the preschool and the pubertal age. These are the times where the highest prevalence of diabetes occurs, the highest incidence of type 1 diabetes is noted in children. There are two major forms of type 1 diabetes, but the commonest type is type 1A, which is an autoimmune destruction of the beta cells of islets of Langerhans in the pancreas, where autoimmunity completely destroys the islet cells, and the children would have deficiency of insulin, absolute deficiency of insulin over many years from months to many years. The second type is type 1B, which is a rare form of type 1 diabetes. Phenotypically, these children have got diabetes, type 1 diabetes, typical type 1 diabetes, with insulin deficiency and a strong hereditary inheritance of predisposition. But evidence of autoimmunity is not detectable in these individuals. This sort of type 1 diabetes, some people call them idiopathic diabetes, and they are highly reported from African and Asian regions. But again, proportion-wise, type 1A is the most common type. Type 1 is a rare form of type 1 diabetes. Type 1 diabetic individuals have got genetic predisposition, and that is going to be triggered by environmental factors that sets in the autoimmune disease process. So the genetically predisposed individual would have some environmental trigger that stimulates the autoimmunity, destroying the pancreatic beta cells. Ultimately, insulin deficiency comes as a result of that. Insulin deficiency is a major cause because of that. Let me have my pointer here. As you can see here, the pancreas is damaged. The beta cell in the pancreatic islets is destroyed from the autoimmune disease process. Then that results in insulin production decline, near absolute deficiency of insulin, and that results in hyperglycemia or diabetes ultimately. Genes that are associated with type 1 diabetes are very, very numerous in number. Several genome-wide association studies have identified multiple genes that are determinant in inheriting type 1 diabetes. Of this genetic inheritance, the major genes that are inherited are genes on chromosome number 6. We have got 23 pairs of chromosomes, as you know, 22 somatic and 1 pair of sex chromosomes. Out of this, chromosome number 6 is a major chromosome that is associated with type 2 diabetes genetic predisposition. On this chromosome, we have got a region called the human leukocyte antigen region, or HLA region, and this region contains several genes. Of this, the major histocompatibility complex gene is a major gene that is a major risk factor for the predisposition to type 1 diabetes. This gene have got different loci. On this locus, on the loci of MHC, we have got different alleles. The DQ and the DR alleles are the major alleles that are associated with causation of type 1 diabetes or predisposition of type 1 diabetes. The studies have also identified some alleles that are protective from type 1 diabetes. But although it's very important to have MHC genes to predispose a person or a child to a diabetes, they are not alone sufficient to cause or to induce diabetes, type 1 diabetes. There are other genes from both MHC region or elsewhere from the genome that have got strong influence on the MHC gene to predispose a person to type 1 diabetes. That's why genetic predisposition alone is not sufficient for a person to develop diabetes, but it's an important part of predisposition to having the disease ultimately. Again, genome-wide association studies have been done to see whether there is a shared gene between type 1 and type 2 diabetes. No gene is found to be shared between the two. The two have got distinct genetic abnormalities of their own. And these predisposing genes of type 1 diabetes are distributed in different prevalence in different populations worldwide. Some countries and some regions have got the highest of this genetic predisposition. This includes the Scandinavian countries such as Norway and Italy, particularly an island called Sardinia, are known to have highest prevalence of type 1 diabetes. And in this region, the diabetogenic genes are found in more than 20 to 25 out of 100,000 population. Contrary to that, other countries, other ethnic groups such as Chinese have got the lowest prevalence of these genes. So genetic predisposition is different amongst different ethnic groups worldwide, the highest being in the Scandinavian countries and in some parts of Northern Europe. Then family predisposition is strong when a first-degree relative have got type 1 diabetes. In the general population who do not have family history of type 1 diabetes, the diabetes risk is about 0.5% type 1 diabetes. When a family member, first-degree family member has got it, the prevalence of risk of having type 1 diabetes increases significantly, 6% if the parents have got diabetes, particularly if the father has got diabetes, the risk increases compared to the maternal risk increase. In general, parental diabetes predisposes 6% of their offspring to have diabetes. If one sibling has got a diabetes, the chance that the other sibling also have got type 1 diabetes is also about the same percentage. If an identical twin has got type 1 diabetes, that is the highest risk for a child. The other identical or monozygotic twin would have a 50% chance of having type 1 diabetes ultimately. Again, this identical twin, despite having shared genetics, the risk of developing diabetes is not 100%. This indicates that other factors would influence the development of diabetes than the genetic predisposition alone. And one other important factor to note is 90% of type 1 diabetics may not have family history of diabetes. This again shows us that although there is a genetic predisposition that can be inherited from a family member, the other family member may not develop diabetes, but the genetics could be there. This is because genetics alone is not sufficient for development of type 1 diabetes, and environmental trigger is very important to result in clinical diabetes. Of this, what is important to initiate the immune process is an environmental trigger or environmental factor that triggers the immune system to mount immune destruction or immune action against the beta cells of the pancreas. There are many proposed possible environmental triggers that could predispose an individual or initiate the inflammatory process of the immune system so that it destroys the pancreatic beta cells. Of this, many are presumptions and associations. The strongest association is found with infectious agents. Viral infection is the most common, that is with stronger evidence. Of this, Coxsackie virus is the most studied one. Individuals who have got Coxsackie virus infection would have a predisposition when they're genetically predisposed already. Change in the microbiota, the gut microbiomes, is also increasingly being reported these days as a possible predisposer for a person who is genetically predisposed to stimulate the immune system and destroy the beta cells. How does the infectious agent result in immune stimulation that destroys the beta cells? This is assumed to be because of similarity between the molecules of the antigens of the pancreatic beta cells and the antigens of the infectious virus. This molecular similarity is called molecular mimicry. Because of this similarity, the body mounts antibodies and cellular immunity against its own cells of the beta cells that are similar with the infectious agent. So molecular mimicry is an important predisposer for infectious agent to initiate the initial inflammatory disease process. And not only, as you can see here, the antigen presenting cells present these antigens of the pancreatic beta cells, the different antigens that we shall see in the subsequent slides. And that stimulates the T cells, where the T cells stimulate the B cells of the immune system to produce immunoglobulins or antibodies. Again, toxic T cells are also stimulated, destroying the pancreatic beta cells. Ultimately, the beta cell is devoid of this functional insulin-producing beta cells. This is what it looks like pictorially. As you can see, the first picture, the first panel indicates an intact pancreatic islet cell. Islet is the island that contains different cells. The most numerous cells are the insulin-producing beta cells. The other ones are glucagon-producing alpha cells. There are delta cells and other type of cells that produce different hormones and chemicals in that island, but the commonest is the beta cells. Human beings have got more than 1 million islands of pancreatic beta cells. It's called the islets. The islands are called the islets. It is very much numerous in terms of its numbers. The brown ones, as you can see here, are the beta cells, and the red ones are the alpha cells producing glucagon. Once inflammatory disease process sets in, the immune system is activated and starts damaging the beta cells. The brown cells are gradually depleted, and finally they are almost gone, infiltrated by inflammatory cells, and only the glucagon or red cells on this picture producing glucagon is what remains. At this stage, the individual stops producing insulin, or no insulin production comes for glucose homeostasis. The antigens that are targeted are mainly insulin is a major antigen that's targeted, and this is the first to be detected in a child. It appears quite early in the life of a child, and the other antigens are targeted subsequent to insulin. So if one has to screen for type 1 diabetes early in the childhood, in the early lives of a child, then insulin antibody is the first to appear. And then one thing that we need to bear in mind is once a diabetes is diagnosed and individual is started on an exogenously administered insulin treatment, do not use insulin antibodies as a screening test, because once we have started administering insulin for a treatment purpose, every individual start producing antibody to insulin within 2 weeks' time. So the antibodies that we detect thereafter may not necessarily be an antibody that the body mounts against the beta cells. It is an antibody that's produced against exogenously administered insulin. So once insulin treatment is started, you do not need to use insulin antibodies as a screening test. The second common antigen that is a target is GAD antigen, or glutamic acid decarboxylase antigen of the pancreatic beta cells, which is detected in nearly 3 out of 4 of diabetic child by the time the diabetes is diagnosed. 70% of them have got positive GAD antibodies. The third commonest affected antibody is insulinoma-associated protein 2, or IA2 antibodies. This usually is an antibody that comes later in the course of the patient's clinical diabetes course, and it appears later than insulin and GAD antibodies. But the most importance that is attached to this antibody is that it is found to be associated with multiple other anti-ILate antibodies. So several antibodies are detected when this antibody is already produced. And this multiple antibody detection is an important predictor of progression to a clinical diabetes. So it is a strong antibody that indicates a progression to antibody destroying the beta cells and diabetes, clinical diabetes coming up. Zinc transporter 8 antigen is another antigen against which antibody is produced. Again, the proportion of this antibody detection in newly diagnosed diabetes is close to 80%. Between 60 to 80% would have positivity to zinc transporter 8 antibodies. The problem with this antigen antibody is the antibody that's produced against this antigen appears quite later than the other antibodies, and it is lost very fast. So you can use it as an early screening tool because it does not appear early in the course, and it does not last very long after the diabetes is diagnosed. So it does not last long means you cannot use it long after the diagnosis of type 1 diabetes. So if you test for it close to the time of diagnosis of type 1 diabetes, it's an important prevalent antibody. Other antibodies are also produced, but the rest are not very important as such. So this graph shows that the seroconversion of a child with type 1 diabetes. Seroconversion oftentimes occur very early in the course of the child's life. It oftentimes peaks between the age of 9 months and 2 years. So a child that's going to develop type 1 diabetes would have the antibody positivity quite early in life. Between the age of 9 months and 2 years is the commonest time when the peak effect of antigen exposure and antibody production comes up. Who would progress to type 1 diabetes once they have got an antibody? Everybody who has got a single antibody should not necessarily go to diabetes. Indicators of diabetes progression are having 2 or more antibodies against the beta cell antigens, islet cell antigens, and studies have demonstrated that an individual who has got a single antibody have got a 15% chance of progressing to type 1 diabetes in 10 years' time. If they have got multiple antibodies to islet antigens, then 70% risk of progression to type 1 diabetes has been demonstrated in a 10 years follow-up study. These studies have been seen in Colorado study, in the US, in the Finnish study, the German study. Actually, the German studies are a couple of them. And all of these have demonstrated that the probability of developing type 1 diabetes when there is multiple antibody detection is very high. The other important indicator of a progression to type 1 diabetes is time at seroconversion. If the child converts to antibody positivity early in the life course of the child, the chance that this child will have type 1 diabetes ultimately is very high. So early seroconversion is also important, particularly high titers of anti-insulin, insulinoma-associated antigen 2 antibodies is the major and the very strong indicator of a chance of progression to type 1 diabetes. And multiple antibodies and early seroconversion and high antibody titers are important indicators for progression. This is important today because now the approval of different medications are coming up in prevention or delaying type 1 diabetes, including monoclonal antibodies. So if a patient or a child at high risk is screened early in the course, these interventions can be done following these screening methods, and that has to be done as early as possible in the child's life. This again is the same thing that I've said. If the child has got multiple antibodies, this is the purple line, is the pink or purple, it's a blood color anyways, and that color is a child who has got 3 islet cell antibodies. Then if you've got 3 antibodies, then that child's chance of developing diabetes is significantly high. The chance of remaining without type 1 diabetes is very low. At the age of nearly 18 years, those who have got 3 antibodies or more would have 100% chance of diabetes development, type 1 diabetes. If the number of antibodies is 2, the green line here, then still there is a very high chance of progressing to type 1 diabetes, but it does not reach that of 3 antibody affected individuals. When there is a single autoantibody to the islet cells, then the chance of remaining without diabetes is significantly high, more than 80% by the time the child reaches 20 years. When there is no antibody, the blue line, then there is no type 1 diabetes that develops ultimately. So this is an indication that the number of antibodies are major indicators or predictors of progression to type 1 diabetes. The other thing is, after the advent of continuous glucose monitoring devices, the more recent developments in diabetes medicine, then if the child is screened, child who has got multiple antibodies is on continuous glucose monitoring screening, and if the child remains at above 140 milligrams per deciliter of blood glucose for more than 5% of the time that the CGM is worn, then the chance that this child would have diabetes is 40% in 2 years' time. If the CGM indicators greater than 5% of the time is spent with a blood glucose of greater than 160 milligrams per deciliter, the chance of developing type 2 diabetes increases to 62%. So having an increased but not diabetes range hyperglycemia is also a very good indicator in multiple antibody positive individuals or children. Hemoglobin A1C is also another indicator that would indicate a possibility of a progression. Even within the normal range, we know that hemoglobin A1C of between 5.7 and 6.4 is pre-diabetes, and anything above 6.5 and above is diabetes range hyperglycemia. Anything within the normal range, less than 5.7%. If there is a 10% or more increase, even within the same normal range, that child has got an increased risk of progression to diabetes. Studies have demonstrated that. So having an increase in the A1C, even within the normal range of 10% or more, is one indicator that this is the disease that is going to progress to clinical diabetes. So this is a summary of what I've said already. Genetic predisposition together with an environmental trigger or triggering event sets in the autoimmune activation. Immunity against different antigens of the islets of the pancreas result in production of different inflammatory mediators, including interferon, interleukins, and cellular toxic T cells stimulation that ultimately destroys the pancreatic beta cell, resulting in insulin insufficiency and deficiency, ultimately complete loss of insulin production, resulting in type 1 diabetes. Type 1 diabetes, when it develops, it has got stages. There are 3 major stages. The fourth stage here is not in many of the literatures that you may read, because it is a continuation of stage 3, the same continuation and progression of over to diabetes. Many literatures and many sources of your reference might tell you stage 1, stage 2, and stage 3. The stage 1 in a genetically predisposed individual, then autoimmunity sets in after an environmental trigger, and that results in production of 2 or more antibodies. If 2 or more antibodies are detected, then this is stage 1 type 1 diabetes. Here, the blood glucose is normal. Then as the time goes on, individuals with 2 or more antibodies would have some degree of abnormal blood glucose, dysglycemia, but that is not high enough to make a diagnosis of type 1 diabetes. So if there's not within the category of diabetes diagnosis, but above the normal range, that is an impaired fasting glucose or hemoglobin A1C between a normal and diabetes range diagnostic criteria, or stimulatory tests such as challenge tests, oral glucose tolerance tests showing a degree of glucose intolerance. These are individuals classified as a stage 2 disease. So stage 2 is 2 or more antibodies together with hyperglycemia that's not within the range of diabetes. And then stage 3 is a full-blown clinical diagnosis of type 1 diabetes per the standard criteria. A fasting blood glucose of more than 125 and a hemoglobin A1C of above or equal to 6.5%, or with a glucose challenge test at 2 hours of glucose of 200 milligrams or above. And these are the standard ADA diabetes diagnostic criteria. So by this time, antibodies are positive. Individuals would have a diabetes range hyperglycemia. This is a stage 3 disease. Some individuals include some sources of your literature might show you that the stage 4 also exists. The stage 4 is only progression of a full-blown diabetes. At this stage, in the early stage of stage 3 or clinical diabetes, some beta cells are still functional, although they are not sufficient enough to maintain normoglycemia. Then these remaining beta cells would ultimately get destroyed and the whole thing goes off in terms of beta cell function. That's what is classified as stage 4 advanced type 1 diabetes. The importance of this is, if you catch a child at a stage 1, the chance of this child to develop type 1 diabetes in 5 years is 44%. If you catch your child at a stage 2 with some degree of dysglycemia, you would be certain that in 5 years' time, 75% of these children would develop type 1 diabetes. So this is also important. The classification is important as to what you have to predict in the ultimate course of the child's life once a child has got a genetic predisposition and immune markers for type 1 diabetes. And the genetic markers, as I have said already, is something that the child is born with, so it's detected from birth onwards. The immune markers are detectable once the environmental trigger has stimulated the pancreatic islet cell autoimmunity, and the metabolic markers. The earlier form can be detected by sensitive tests such as glucose challenge test, the dysglycemic phase at stage 2, or a full-blown symptomatic hyperglycemic individual can have a full-blown symptom presentation and then hyperglycemia. So genetic starts from birth and the others come through time. This is the time it takes. A genetically predisposed individual would have the environmental trigger anywhere between the 9 months and 3 years of the lifetime. Then the environmental factor triggers it, autoantibodies are produced, cell-mediated immunity is stimulated, and the beta cells are destroyed. And over months to years, this progresses to an overt diabetes. Overt diabetes is preceded by some degree of dysglycemia that is short of diabetes diagnosis. This phase is a honeymoon phase that we all know probably from our care of our patients. Honeymoon phase is a child who is on the course of developing type 1 diabetes. Before the clinical symptoms come, if some incidental things can happen in child, such as respiratory infections, for instance, gastrointestinal infections, for instance, then that child would be under stressful condition. Then the beta cells cannot compensate for that stressful demand. Then the child's hyperglycemia goes off, and the child would present oftentimes with acute crisis such as diabetic ketoacidosis. And this is a diabetes diagnosis that comes as a result of this antecedent event. Once this antecedent event is treated and the child recovers, the remaining small amount of beta cells can still continue functioning. The child might require a lesser amount of insulin, and sometimes even a short while discontinuation of insulin could be possible. That's called the honeymoon phase. But this does not last very long. This is only for a few months, and the ultimate remaining beta cells will be destroyed, and ultimately the diabetes diagnosis continues to be a standing and persisting diabetes diagnosis. So this is what it looks like. Progression of diabetes from predisposition and environmental trigger stimulation takes between months and years based on the intensity of the inflammatory disease process. So this is what I can tell you about type 1 diabetes in brief. Thank you for having me. Appreciate it.